Hello, I'm Dr. Julie Louise Gerberding, Director of the Centers for Disease Control and Prevention. Thank you for joining us today for this important program. We are here today to give you an update on the evolving investigation of SARS, the severe acute respiratory syndrome that has been an emerging global problem over the last several weeks. In collaboration with the World Health Organization, CDC and other international colleagues are continuing to investigate and implement measures to control the expanding SARS outbreak. We are working to understand the modes of spread, the causes of illness, and what really is the best way to prevent spread and treat patients with SARS. Of course, our greatest concern is for the patients, family members, and care providers who are suffering from this illness or worried about this illness. We extend our sympathy to you in this difficult time. We are encouraged that many SARS patients are improving over time. We continue to regard a previously unrecognized coronavirus as the leading hypothesis for the etiology of this condition. Laboratory evidence is mounting from a number of international laboratories that this indeed is the case. Laboratory investigators in many countries continue to explore coronavirus as well as other potential viruses as the cause of SARS. We will update these findings as we go forward on the scientific investigation. We are at a situation in time where we recognize that the disease is still primarily limited to those who have had close contact with SARS patients. This includes healthcare personnel who have taken care of SARS patients, household contacts, and travelers to affected areas. We believe, based on what the investigations have shown us so far, that the major mode of transmission still is through droplet spread when an infected person coughs or sneezes and droplets are spread to a nearby contact. But we are concerned about the possibility of airborne transmission across broader areas and also the possibility that objects could become contaminated in the environment and serve as modes of spread. Today you will hear from investigators at WHO and CDC as well as clinicians who have been involved in the affected areas of Hong Kong and Vietnam. This program will provide an update of the SARS investigation and clinical findings and focus on providing guidance for preventing transmission of this disease within hospitals and other healthcare settings. As we learn more or we learn something different as we go forward in the investigation, our guidance will be updated. Please check both the WHO and CDC website for the latest information. We thank you for taking the time to view this program. Please know we are doing everything we can to solve the mysteries of this epidemic and limit its spread.
And thank you, Dr. Gerberding. Hello, everyone. I'm Kisa Daniels. Welcome to Preventing the Spread of Severe Acute Respiratory Syndrome, or SARS. We are coming to you live from the Centers for Disease Control and Prevention in Atlanta, Georgia, and the World Health Organization in Geneva, Switzerland. This program is sponsored by the World Health Organization and supported by the Centers for Disease Control and Prevention. The goal of today's program is to provide the public health and clinical communities some basic information regarding the SARS outbreak and guidance to prevent transmission. At the end of this program, you should be able to, number one, describe the current outbreak of SARS, describe strategies to prevent transmission in hospitals and healthcare facilities, and number three, recognize the need for international cooperation to stop the spread of SARS. Also, during today's program, we will not conduct any live on-air question and answer periods, but you are encouraged to review the WHO and CDC websites for all available information and updates. The web address for the World Health Organization is www.who.int. The web address for the CDC, www.cdc.gov. If you're having technical trouble receiving our signal, you can call us here at CDC. The number to dial is 800-728-8232. If you're viewing the program from outside of the United States, the technical number to call is 404-639-1289. Now, viewers are encouraged but not required to register and evaluate the program on the CDC Training and Continuing Education online system. That address is www.phppo.com. www.cdc.gov/PHTN online. A certificate of attendance will be awarded to participants who complete the evaluation, although continuing education credit is not available for the broadcast or webcast. Registration and evaluation, however, will provide some valuable feedback to CDC. Participants will have about a month until May 4th, 2003 to register and evaluate this program. The course numbers, SB0128 for the satellite broadcast, and then WC0028 for the webcast. Questions about registration should be directed to 800-41-TRAIN or 404-639-1292, or you can email your questions to ce@cdc.gov. And when emailing a request, please indicate SARS in the subject line. Now, I'd like to introduce the first of two guests who will be coming to us from the World Health Organization's headquarters in Geneva, Switzerland. Dr. David Heyman is Executive Director of Communicable Diseases for WHO. Dr. Heyman will discuss SARS, a previously unrecognized emerging disease. He will review the importance of SARS in terms of global health and its impact on healthcare systems. Dr. Heyman.
Thank you, Kisa. During the past 3 weeks, the world has come to know a newly identified infection in humans, the severe acute respiratory syndrome, now commonly called SARS. This disease occurred at a time of heightened surveillance in the world for influenza, because on the 17th of February in Hong Kong, 2 persons with avian influenza, H5N1, had been identified. And at the same time, the world became aware of an outbreak of a respiratory disease in Hong Kong. So in this environment with heightened surveillance, if we can turn to the first slide, you can see that what we did was we responded to the unexpected in the middle of this slide. This slide shows you how the World Health Organization has a framework in which it can respond to an unexpected infectious diseases. Over the top of this overhead are the international health regulations, which are a set of regulations which have been agreed to by our 192 member states, which provide the mandate for global surveillance or global alert and response. And under that, we work with known risks such as influenza, with unexpected events such as what's happened in the last 3 weeks. And at the same time, we have a part that increases preparedness, setting out norms and standards for countries in their surveillance and response activities. Now, these international health regulations helped us as we first described on the 26th of February in Hanoi a new disease. This was a disease which we feared was influenza because it was a very severe disease which had occurred in a businessman, 48-year-old businessman, who came to Vietnam by way of Hong Kong from the Guangdong province in China. This man developed a high fever that rapidly progressed to an atypical pneumonia and acute respiratory failure requiring ventilation. In Vietnam, there's a WHO office, as in most developing countries, and the epidemiologist from that office, Dr. Carlo Urbani, raised the alarm after he had seen this case of atypical pneumonia, and also had seen some health workers who became sick from this same, what he presumed was the same infection. He notified WHO at that time. Now, in our alert and response operations at WHO, we take intelligence such as we got from Dr. Urbani. We then verify that information. We respond as necessary to that information, and in this case, the country of Vietnam requested assistance from WHO. And through our Outbreak Alert and Response Network, we were able to mobilize a team of 9 persons to work in Vietnam with the government to investigate and contain this outbreak. And then the follow-up continues because this team, or parts of it, remain in Vietnam. New members are going and coming as we continue the follow-up. Now, this disease occurred in Vietnam on the 26th of February. At the same time, a similar disease occurred in Hong Kong, and outbreaks occurred in many different hospitals. There are now 10 hospitals affected in Hong Kong. That outbreak continued, and again, WHO, through its Outbreak Alert and Response Network, provided a response team. And at the same time, we were working with the government of China because there was a similar outbreak in the Guangdong province. On the 11th of March, we mapped out what was going on with this disease in the various sites, and on the 12th we put out a global alert, but a moderate alert about this disease to different countries, describing what was occurring in the countries. This press release was picked up by ministers of health throughout the world, and then on the 14th of March, we received a report from Canada that they had detected a disease which was very similar to this. When we had that report on the 14th of March, we put it into our system of analysis and decision-making, and we decided that because this looked to be an infectious agent, and possibly a new agent, which at that time was affecting mostly health workers, it was a nosocomial infection, which could place a burden on healthcare systems. And because there was a possibility that this could become pandemic worldwide, we became alarmed. We had seen it travel out of Asia into Canada, and at the same time we knew that there was no treatment or vaccine that could prevent it. So we raised a global alert with all these things in mind, telling countries about this agent on the 12th of March, on the 15th of March rather, and also providing an emergency travel advisory and a case definition. This was done to alert countries that now this disease was on the move. It was also to alert airline passengers that they might be carrying this disease and that they should have a high suspicion of this disease should they become sick with the signs and symptoms which were described. So we had in place at that time a global system which provided a case definition, which asked countries to report if they had this disease, and was helping to make sure that the disease did not travel further internationally. We believe that this system was quite effective in working on describing the epidemic to the world, and also in stopping the spread of this disease within countries to which it was imported. We believe that by this alert, the 18 countries which now have this virus, and possibly more are coming, that these countries have been able to contain the outbreak, Canada being the last country in which this virus arrived before the alert had been made. So now back to Atlanta.
Dr. Heyman, thank you so much. And you've just shared with us, of course, the importance of countries working together to halt this outbreak. And certainly we all understand that we are still in the midst of this problem and tracking its developments as we speak. For the remainder of this program, we will hear from speakers from WHO, Hong Kong, and CDC, who will describe the current status of the investigation and some recommended measures to stop the spread of SARS. Right now, though, we want to return to Geneva, Switzerland for our very next speaker, Dr. Julie Hall. And Dr. Hall will elaborate on the epidemiology and the current status of the SARS outbreak. Dr. Hall.
Okay, thank you, Keisha. Dr. Heyman ran through some of the responses and the work that's been going on over the past few weeks. To recap and to give a little bit more information on what has been happening, WHO, in collaboration with the Global Alert and Response Network, a partnership network of over 150 different institutions throughout the world, has mounted an unprecedented global response to the threat of SARS. This response has taken place in 6 different areas: epidemiology, laboratory, clinical, logistics, field teams, and the production of guidance and policy materials.
In terms of epidemiology, global surveillance is now in place, and reporting of cases, probable and suspect cases, to WHO is now taking place. We're also developing a system of collecting more data on individual patients from affected countries so that better global analysis of this problem can take place. There's a collaborative network of epidemiologists from both affected and non-affected countries around the world working on key issues such as transmission, incubation period, and other things that we really desperately need to know more about in terms of this disease. And I'll be talking later in a little bit more detail about what we know about the global epidemiology to date. Second area of response has been around laboratories. 12 laboratories in 10 different countries from around the world have collaborated to try and identify the causative agent, and Dr. Hughes will be talking later about the work to date. This collaboration of the 12 laboratories has meant that data and findings can be shared at a very early stage, and diagnostic tests are now underway. A third area of collaboration that has taken place is around clinical findings, and there's now a network of clinicians from around the world, particularly in those countries that have been affected by SARS, that are working together to be able to produce more detailed information about the clinical syndrome that is SARS and about treatments that have been tried and what has been effective. And Dr. Sung will be talking more about this later as well. In terms of logistics, bases have been established in Thailand and in Manila and in other places around the world. And these logistic bases are there to try and ensure that the protective equipment that is so important to try and reduce the transmission of SARS, and that Dr. Chirilla will be talking about later, is in place and available to affected countries as quickly as possible. Field teams, as Dr. Heyman talked about, have been mounted from WHO and the Global Alert and Response Network, and they're working to assist countries that have been affected to deal with this problem. Their particular areas of interest are around infection control and trying to gather more epidemiological information. And then lastly, WHO, with its partners, has put together various policies and guidance documents, and they're all available on the WHO SARS website. These policies cover the case definition, surveillance and reporting procedures, as well as guidance on case management, on the management of contacts, on infection control, particularly within the hospital setting. In addition to that, as Dr. Heyman mentioned, travel advice to travellers about the awareness of symptoms, as well as advice to airlines and other travel companies has been provided, so that passengers can be screened, and there's advice to those companies as to what to do if somebody falls ill in transit. In terms of global epidemiology then, I'll just outline briefly the findings to date. As of today, there are over 2,000 cases, probable cases of SARS have been reported worldwide, and over 60 deaths have occurred. The majority of cases of SARS have occurred in this 30 to 50-year-old age group. And this is probably reflective of the fact that the majority of cases have been healthcare workers. There have been very few children reported as having SARS to date. However, in the last week or so, the numbers of children and those under the age of 16 with SARS has increased. We're seeing 3 generations now of infections and transmission of SARS. The first generation, the first wave of infections, being index cases. The second wave being healthcare workers and close contacts of the index case. And then in some areas, we're also seeing a third wave of transmission to family members of healthcare workers. In Hong Kong, there is some evidence that there may be community transmission and a possible fourth generation of transmission. However, this is under intense investigation at this moment in time. Data to date collected from around the world shows that the attack rate for this disease in hospitals where infection control procedures are not in place can be greater than 50%, highlighting the real need for infection control. The incubation period of SARS ranges from 2 to 7 days, although there have been reports of a much shorter incubation period of around about 1 day and a longer incubation period in a very small number of cases, up to 10 days. The mode of transmission of SARS has yet to be fully explained. The major route appears to be very close contact. However, other routes of transmission still have to be investigated further. The mortality rate of SARS globally is running at about 4%. And the majority of those people who have died of SARS have been over the age of 40 and have had comorbidities, other underlying conditions. However, the numbers are very small, and one must be cautious in trying to interpret this information at the moment. So, in summary, SARS is an important disease. Global surveillance has allowed us to detect it at a very early rate, and global reporting has shown that whilst numbers are increasing globally, in the majority of countries, after the global alert had taken place, no further transmission of imported cases has taken place. And that's all from me, so back to Atlanta.
And thank you, Dr. Julie Hall, Geneva, Switzerland. Next, we go to Dr. Joseph Sung. He's professor of medicine at the Chinese University of Hong Kong and chief of medicine and therapeutics at the Prince of Wales Hospital in Hong Kong. Dr. Sung will provide information on the clinical presentation and symptoms of SARS, course of disease, and outcomes as seen in initial patients in Hong Kong.
I report here an outbreak of SARS in Hong Kong. On the March of 10th, we have found 18 healthcare workers in our hospital reported sick. On the next day, we actually found 50 of them reported to have fever, chills, and rigors. When we screened them, we admitted 23 of them already have chest X-ray changes. Up to March 25th, at the Prince of Wales Hospital, we have admitted up to 156 patients, including 130 cases with direct or indirect contact with our index case. And here is the picture, shows that our index patient who had, who was actually a 26-year-old male with pneumonia, with history of traveling in China. And there were 112 cases, including healthcare workers and medical patients staying in the same ward who contracted the disease through direct contact with him. 26 more cases who had contracted the disease through contact with our secondary cases, and these we call them tertiary cases. Demography shows that out of its 138 cases, there were 72 female, 69 of them were healthcare workers, including 20 doctors, 34 nurses, and 15 allied health workers. We have 16 medical students doing an examination, a clinical examination on that day, and they all got the disease. 19 patients staying in the same ward were also affected. It shows the common symptoms of SARS in this cohort. Everybody has fever. Chills and rigors was reported in over 70% of the cases, myalgia in 60%, and dry cough, headache were reported in over 50% of cases. We also have 40% of patients complain of dizziness. Less common symptoms include sputum production, sore throat, running nose, nausea, and diarrhea. And with white cell count lower than 3.5, it was found in 34% of our cases on that mission. And as you can see from the graph here, the white cell count actually dropped as the disease progressed. We also found lymphopenia as a predominant feature of this disease. Many patients have a lowish white cell count, which continue to drop as the disease goes more severe. And altogether, we have about 70% of patients with lymphocyte count dropped to below 1,000 per ml. We also found a low platelet count as a very common feature in the blood count. Thrombocytopenia was reported in 44.8% of our patients, and the platelet count also continued to drop as the day goes by. The clotting profile of the patient is also deranged. We found a prolonged APTT, which is defined as longer than 38 seconds, in 42.8% of the patients. Elevated D-dimer was also reported in nearly half of our patients. And actually in 2 patients, we have profound DIC documented. Serum chemistry is shown here, which indicate that patients can have elevated transaminase level in 23%. Elevated CPK level was reported in about 1/3 of our case. Sometimes the CPK level was very high, but in all the cases that we have checked, the CKMB and the troponin levels were not elevated, indicating that the CPK is not coming from the myocardial muscle. We also found elevated LDH, lactate dehydrogenase level, elevated in over 70% of our cases. And later on, you will find that this LDH level does seem to have a prognostic factor. Hyponatremia and hypokalemia was occasionally found in our patients. This is a typical example showing the progression of chest radiographs from day 1, day 2 to day 4 of a patient. A lot of patients start off with a very clear chest X-ray, and then we see a diffuse patch, usually peripheral and basal situated. And in early phase, it was mostly unilateral. And then at around the end of the first week, they start to have more diffuse infiltration and consolidation pattern involving both lungs, and the progression of the disease is extremely alarming. In cases when we have difficulty to find abnormality on the plain chest X-ray, we'll perform a CT scan in which we find typical consolidation pattern at the base of the lung, again in the more periphery part of the lung, which mimics the conditions called BOOPS, which is bronchiolitis obliterans organizing pneumonia. And we find CT thorax extremely useful when the chest X-ray could not detect anything, but clinically, patient symptoms suggest of SARS. Microbiology investigations include sputum culture, nasopharyngeal aspirate for culture, as well as PCR. Here is the result. In general, we have very little positive yields from these cultures, which includes Haemophilus influenza in 3, strep pneumonia in 1, and Klebsiella pneumonia in 1 case only. On NTA, we found 1 influenza A, 1 influenza B, and 2 cases of RSV. However, when we performed electron microscopy on the NTA, we do find bioparticles resembling both paramyxovirus as well as coronavirus in our case. This is the protocol of our treatment from the very first day. We treat patients with fever, chills, and rigors that's suspected to have SARS with a conventional antibiotic, and we start with a beta-lactams as well as a quinolone. And 2 days later, if the fever still doesn't respond, we'll give the patient ribavirin and steroid in combination. Because of the large number of patients that we see at the same time, and because of the shortage of intravenous ribavirin in our hospital at that juncture, we chose to give IV medication to those with more severe illness and desaturation of oxygen. Oral ribavirin and oral prednisolone was given to more stable patients in the dosages indicated here. If patient does not respond, which means the fever doesn't subside and chest X-ray continue to progress, we gave the patient intravenous pulse therapy of mifeprednisolone at 500 milligrams per day for 2 consecutive days. If after 2 pulses of steroid, the fever still persists and there's no signs of improvement, then we will have to give the patient the 3rd or even sometimes the 4th pulse of steroid. And in most patients, they will respond to this treatment, fever subside, chest X-ray improved, and the oxygenation improved. For those who still have not responded, we resort to use convalescent serum that we collect from patients who had recovered from the disease. And in 3 patients, we have also tried plasma exchange as our last resort. During this time, some of the patients may deteriorate and the oxygen saturation goes down. Admit them to intensive care unit for further observation and maybe even require mechanical ventilation. This is the outcome of our first 138 cases. Among them, we have admitted 32 patients into the intensive care unit. That constitute 23%. 19 of them thus required ventilation, and the number of patients who succumbed includes 2 with myodysplastic syndrome, 2 patients with liver failure, and 1 patient who had heart failure. All these 5 cases were originally patients from the medical ward, and they are all belong to the older age group, and they have comorbid illness to start with. None of our healthcare workers or medical students to date died from the disease. When we look at the chest X-ray resolution, 82% of our patients had more than 25% of resolution of their chest shadow. This is done by reading the digitized X-ray using our computer. 70% of patients have more than half of the X-ray shadow resolved in a median duration of 7 days. The postmortem findings of 2 cases show that there is early phase of alveolar damage with pulmonary edema, hyaline membrane, and it also shows features suggestive of ARDS. Lymphocytic inflammatory infiltrate, vacuolated and multinucleated pneumocytes were also seen, and occasionally we also find viral inclusion bodies. This is the number of factors that we have analyzed to predict which patient require ICU admission or which patient eventually die. And you can see that in the highlighted columns, rows, these factors include older age, male sex, highish neutrophil count, low sodium level, high urea count, high CPK level, and high LDH level. This is based on univariate analysis, and these 8 factors were found to be significant. On multivariate analysis, we found only 3 factors independently predict poor outcome. This include advanced age, and we use a cutoff of 40 years to differentiate the high-risk group from the low-risk group. The LDH level at a cutoff of 350 units per liter also predicts which will be the poor outcome patients. The neutrophil count also seems to indicate who has a poor prognosis. Those with a highish neutrophil count thus have a more likelihood of ICU admission or death. However, we cannot find a clear cutoff point for neutrophil counts in this analysis. These are the dosages of ribavirin that we use. For intravenous, we use 5 to 8 milligram per kilogram 3 times daily, and for oral dose, we use 1.2 grams. And that is because we understand that the oral bioavailability of ribavirin is only 45%. Therefore, we need a much higher dose when the drug is given orally. We have considered very carefully whether or not we should use nebulized ribavirin, but since we learned from the bitter experience that our index case actually spread the infection by using nebulizer on the day of admission, we have decided not to use aerosolized ribavirin in our treatment. And I want to show you here a temperature chart of a patient which responds to pulse steroid. You can see the red line represents the temperature and the blue line represents the pulse. After 2 days of oral ribavirin and oral steroid, patient still did not respond, and his chest X-ray started to deteriorate. So we gave him 1 pulse and 2 pulse, and the temperature gradually settled, but only to come up again on the 26th. At that juncture, a 3rd pulse of steroid was given, and then he started to improve there onward. This is a chest X-ray of one of our patients who starts with only a patch in the right lung 3 days later, he had very diffused bilateral airspace consolidation, at which point he was admitted to the ICU and he was given 100% oxygen. This patient was treated with IV ribavirin and IV hydrocortisone for almost 10 days without much improvement, although his fever subsided, but his lung continues to deteriorate and his oxygen saturation has always been marginal. So finally, we decided to give him pulse steroid, and in the lower part of the slide, you can see the radiograph after 2 days of steroid, pulse steroid, and now he is recovering outside the ICU. This is another patient who received pulse steroid, and you can see on the left, he has more consolidation and diffuse white patchy consolidation compared to the right. After he received pulse steroid, there's more airspace opens up and his condition improved. We do have some side effects using larger doses of methylprednisolone. This includes superimposed infection in 18 cases. We cover them with anti-pseudomonas therapy, anti-MRSA, and antifungal therapy. Patients may also develop hypokalemia and hyperglycemia, but those are easily correctable. We have used convalescent serum in cases when after 3 pulses of steroid, the patient still does not respond. And this is the protocol of our convalescent serum preparation. We asked for donors who had recovered from the illness become afebrile for at least 3 days, and chest X-ray showed definite resolution. Convalescent serum is given to patients who had persistent fever, as I said, and also when fever recurs in some patients who initially respond to steroids and with leukocytosis, in which case we are not quite sure whether this is reactivation of the disease or whether it is superimposed infection. So in these patients, convalescent serum is considered to be safer than giving them further pulses of steroid. This is an example of a patient who responded to convalescent serum. Again, in the red line, it shows the temperature, and the blue line shows the pulse of the patient. After the first 3 pulses, MP indicates methylprednisolone. Patients still have high swinging fever, and at that juncture, on the 22nd of March, we gave him convalescent serum, indicated by CS here. And then you can see that the fever comes down very nicely, and the patients recover from the illness. Well, this is a typical example of a positive response, but among 12 cases that we have given convalescent serum, some patients respond, but patients were also given steroid and antibiotic during that time, so we are not quite sure whether convalescent serum or whether antibiotic is the major reason for recovery. This is the patient who received convalescent serum. On day 1, day 2, and day 3, the disease progressed despite the use of ribavirin and steroid pulses. But after convalescent serum on day 7, you see remarkable recovery of his chest radiographs. The lesson that we have learned from the last 3 weeks is that high-dose steroid should be given early to stop the progression of the disease and to prevent further deterioration of lung function and ICU admission. We have not used nebulizer or non-invasive positive pressure ventilation because we believe that it would further spread the disease and it would endanger healthcare workers looking after these patients. And in patients who had been slowly recovering, we found that sometimes their lung volume shrinked and atelectasis stepped in. Chest physiotherapy would be very useful in those cases. That is the result of our first 138 cases. And of course, after that, we have more patients. While we adopt a more aggressive approach in the therapy, we find that the treatment result is better. So unfortunately, in this crisis, we cannot have a controlled data to prove that this therapy is valuable. but I do believe that both ribavirin and steroid will be required.
And that again, Dr. Joseph Sung, coming to us from Hong Kong. Our next speaker is right here in the studio with us. Please welcome Ms. Linda Chiarello from the Centers for Disease Control and Prevention, Division of Healthcare Quality Promotion. She recently returned from the field investigation team in Hanoi, Vietnam. Ms. Chiarello will provide an overview of the key principles for preventing transmission of SARS in hospitals and in other healthcare facilities. Ms. Chiarello, welcome.
Thank you, Kisa. I am pleased to participate in this educational program, and I say hello to colleagues around the world who are listening in today. During my recent visit to Hanoi and Hong Kong, I had the opportunity to experience firsthand the challenges confronting infection control, public health, and other health professionals who are trying to help prevent the spread of this disease. I was impressed with their dedication and commitment and energy. This is not easy, and we don't have all the answers. However, despite the limitations of our current knowledge, emerging evidence suggests that the routes of transmission are familiar, and the tried and true measures to prevent transmission in hospitals will work here as long as infected patients are detected and isolated early in the course of their disease. In the time available, I plan to highlight the basic principles of infection control for preventing SARS transmission in healthcare settings. May I have the first graphic, please? Described here are 3 premises that provide a basis for the development of a SARS prevention program. We begin with the assumption that all SARS patients, regardless of disease severity, are highly infectious until proven otherwise. We also assume that hospitals will have to implement measures that will protect vulnerable patients, staff, and visitors, as well as prevent spread to the community. And until the epidemiology of SARS is better understood, infection control measures must target all possible modes of transmission, including airborne, droplet, contact, and through contaminated materials or fomites in the environment. Strategies used to control the spread of other communicable infections in hospitals are familiar to this audience, but bear repeating in the context of a SARS prevention strategy. Administrative measures are especially important, including good communication, education, clear policies and procedures, and enforcement of adherence. Because there is a concern for possible airborne dissemination of this virus, engineering measures to control and maximize air exchange most certainly apply. The recommended personal protective attire for SARS is intended to prevent exposures to a SARS agent that might be spread through the air, respiratory droplets, and direct and indirect contact with respiratory secretions. These include the role of masks, eye protection, gowns, and gloves. In addition, protecting the environment of care through surface cleaning and disinfection and using care in the handling of waste and laundry are components of a broad infection control strategy. It is helpful, perhaps, to think of SARS prevention in the context of objectives that need to be achieved. The first one is early detection of possible SARS cases through traditional surveillance and screening methods. The second is containment of infection through source control measures, such as having the patient mask or cover his or her nose when coughing or sneezing, through patient placement and the control of ventilation. Third is protection of personnel and the environment of care through the infection control strategies I just mentioned. And fourth is hand hygiene. Hand hygiene is the cornerstone of disease prevention. Hand hygiene protects patients. It protects healthcare personnel, and it protects the environment of care. While hand hygiene is not a specific objective, perhaps, it is important for infection control and therefore merits its own distinction. Administrative measures are critical for ensuring effective implementation of infection control for SARS. Infrastructures currently in place in many healthcare facilities to address concerns about bioterrorism will certainly serve in this setting as well. Systems for communication, supply acquisition and distribution, and traffic control are some of the administrative measures that need to be addressed as part of a broad SARS infection control strategy. Responsibility should be assigned for placing SARS patient at the time of admission, implementing and enforcing infection control measures, and monitoring for transmission through some of the surveillance strategies I will mention later in the presentation. Administrative controls are also needed for limiting contact with SARS patients. At the discretion of the facility, this might require setting limits on visitation and designating a cohort of care providers for the care of SARS patients only. As I mentioned, a key objective is early detection of infection and is critical to containing and preventing the spread within a healthcare facility. A goal of this teleconference is to inform and educate clinicians on signs and symptoms of SARS and to create, therefore, a heightened index of suspicion for SARS in patients who may be seen in primary and emergency care areas. It is also important to have systems in place to intervene at the point of the initial health care encounter. These may include use of signs to alert patients, such as the one seen here. Visual alerts also serve to instruct patients, and by providing a supply of surgical masks at the entry to reception areas, encourage containment of respiratory droplets. Patients who may have SARS should be segregated from other patients as soon as possible, and preferably placed in a private room. Communication is another very important aspect of early detection, and infection control personnel should be immediately notified when a possible patient with SARS is admitted to or presents to the facility. And this will ensure that the appropriate implementation of measures for infection control following admission, as well as the notification of public health authorities. Lastly, the use of personal protective attire that I will describe shortly should begin at the first point of patient contact and continue until the point of discharge or determination of non-infectiousness. The second objective is containment of infection. And containment of infection begins with source control and segregation or separation of patients with SARS-like symptoms. However, one of the key infection control measures here is to contain and safely remove the infectious air around the patient. The preferred option is to place SARS patients in a private room that is under negative pressure relative to the surrounding air, with air filtered to the outside. The door should remain closed, and access should be limited to those persons who must enter for purposes of providing patient care. However, in many areas of the world, negative pressure environments are not available, and appropriate accommodations must be made. Natural ventilation can be maximized by opening windows, and air can be directed outside through the use of exhaust fans. Surgical masks may be worn by the patient as tolerated and safe for patient care. Containment of infection also involves decisions about patient placement. A private room for SARS patients is preferred when available. SARS patients should not be placed in rooms with other patients who do not have a SARS-related diagnosis. In some cases, because of the number of SARS patients being admitted, it has become necessary to cohort SARS patients on designated wards. When this is done, the same ventilation strategies should be considered. It is worth noting here that when SARS wards are established, patients who are undergoing initial evaluation for possible SARS should not be placed in a SARS ward. Instead, to avoid unnecessary exposure, in the event such patients are not infected, they should be placed in a private room until SARS has been ruled out. An administrative measure to help contain infection and prevent unnecessary exposure is to limit the number of patient contacts. This can be done through various options for visitor restriction, as well as by using dedicated staff to care for SARS patients. This is probably more important in a situation where SARS is spreading in the community or there has been transmission within the hospital. Options for limiting visitors are listed here. However, these decisions are best left to individual healthcare facilities and may depend on transmission patterns that have been observed. The third objective is to protect patients and the environment of care. As mentioned earlier, until the epidemiology of SARS is clear, all modes of transmission must be considered when determining appropriate measures for protecting personnel. Protection of the respiratory tract is necessary to prevent airborne and droplet transmission. An approved respirator, such as an N95, is recommended for preventing exposure from airborne droplet nuclei. In the United States, at least, qualitative fit testing is required before using this device. Large infectious droplets may be generated when a patient coughs, sneezes, or speaks. Dispersion of these droplets is generally limited to the area close to the patient. A standard surgical mask is recommended for preventing exposure to respiratory droplets. However, because both respiratory and droplet routes of transmission are being considered, an approved respirator is the preferred mask for personal protection. However, if a mask is not available, a surgical mask should be worn. Masks should be applied when entering the room or ward housing SARS patients, and ensuring a snug fit over both the nose and mouth is necessary to optimize the protective benefit of this device. The mucous membranes of the eyes also must be protected from exposure. Goggles or face shields offer the necessary protection from respiratory spray that might be generated during patient care. Protective attire is necessary to protect exposed skin as well as clothing of healthcare personnel. Gowns, disposable or washable, and disposable gloves should be worn for contact with patients and their environment. It will be therefore necessary to don this attire prior to room entry and remove it before leaving the room. In wards dedicated for the care of SARS patients, healthcare personnel generally wear the same gown over the course of a shift and change it only if it becomes soiled. However, gloves should be routinely changed and hand hygiene performed between patients. Head or shoe covers also may be used if dictated by cultural norms or regulations. Since there is evidence that coronavirus can survive on environmental surfaces, protection of the environment of care is critical to interrupting transmission. Standard measures for handling contaminated materials should be followed. Some measures, such as those for infectious waste, may be dictated by local regulations. Soiled linen and laundry should be handled carefully, including the avoidance of sorting and other measures that could generate airborne contaminants. Designated bags should be used for containment of contaminated linen and laundry, and standard laundering procedures already in place should be followed. Bleach is not necessary, but may be added to the wash cycle if desired. Eating utensils used by patients with SARS should be washed in a dishwasher or by hand using dish soap and warm water. Disposable dishes and utensils are not considered necessary. There is no need to change the type of disinfectant used based on concerns about environmental contamination with the SARS agent. Either a hospital-grade disinfectant or a 1:100 dilution of household bleach and water may be used. It should be assumed, however, that the immediate environment around the patient with SARS is heavily contaminated. Daily cleaning will reduce this bioburden and should focus on areas close to the patient, including bed rails, over-bed table, nightstand, sinks, lavatory facilities, and other equipment in the room. Cleaning will certainly be facilitated if there is limited clutter in the patient's environment. Following patient discharge, the room and all reusable patient care equipment should be thoroughly cleaned and disinfected in accordance with current cleaning and reprocessing procedures. The fourth key objective is hand hygiene. As I mentioned earlier, hand hygiene is the cornerstone of prevention and should be performed following all contact with suspect and probable SARS patients and their environment. Hand hygiene methods include traditional hand washing with soap and water, followed by drying, preferably with a disposable towel, and the use of alcohol-based hand rubs. Hand washing should be performed anytime the hands are visibly soiled, while alcohol-based hand rubs may be used as an alternative when the hands are not visibly soiled and when hand washing facilities are not available in the patient room. There are a few other considerations that I would like to mention as part of this presentation. As Dr. Sung mentioned earlier, the use of nebulizers has been thought to be associated with possible transmission to medical personnel in his facility. Therefore, when possible, nebulizers and other cough-inducing procedures should be avoided. If necessary for patient care, such procedures should be performed in a separate area, in a negative pressure environment, with personnel wearing appropriate protective garb. Patient movement should also be limited to the extent possible. If transport is required for patient care, the patient should wear a surgical mask and clean attire or cover gown. Personnel who have been exposed and might be incubating SARS need to be monitored for evidence of early disease or infection. Surveillance of SARS contacts is also necessary for assessing the effectiveness of infection control measures. A list of healthcare personnel contacts should be maintained, and personnel should be monitored for signs and symptoms of SARS, if not daily, at least every 2 or 3 days. A listing of other patient contacts also should be created for surveillance purposes. The strategies and objectives of SARS prevention are shared globally. However, several factors will influence their interpretation and implementation. Country differences and even differences within countries are likely and should be appreciated. We need to understand that cultural patterns of healthcare delivery, including the use of families as primary care providers, may be an important influence on the type of measures implemented for infection control. The hospital infrastructure, when there is the capacity to engineer the direction of airflow, is an important consideration. Knowledge and experience of healthcare personnel in caring for patients with a communicable disease and their familiarity with principles of transmission-based isolation techniques will vary. The availability of resources, both in developed and developing countries, is a very serious concern as these resources dwindle with the rise in SARS cases. Decisions are necessary about reuse of many of the protective devices that are used for healthcare personnel. And finally, variation in infection control will probably be observed as a result of the level of SARS in the community and whether transmission has been observed within the healthcare environment. I would encourage you to go to the WHO and CDC websites for the most current information and recommendations for infection control prevention for SARS. In the final analysis, prevention is primary. Early detection and implementation of the infection control measures I just described will have the greatest impact in protecting healthcare personnel and healthcare facilities from SARS. Thank you.
And thank you, Ms. Chiarello. We appreciate your expertise. Our final speaker also here in the Atlanta studios is Dr. James Hughes. Dr. James Hughes is Director of the National Center for Infectious Diseases here at CDC. Dr. Hughes will talk to us first about the status of the laboratory investigation of SARS. Dr. Hughes.
Thank you very much, Kisa. CDC is one of 12 institutions in 10 countries working collaboratively under WHO leadership to investigate SARS. On March 14, CDC Director Dr. Julie Gerberding activated the CDC Emerging Operations Center. This was the day, as Dr. Heyman mentioned, that the cases in Canada were first reported to WHO. To date, approximately 30 CDC staff have been deployed to assist in the investigations in Hong Kong, Vietnam, Taiwan, Thailand, Canada, and most recently in mainland China, working in collaboration with colleagues from around the world. In addition, nearly 300 CDC staff are currently working at headquarters and throughout the United States to assist colleagues at the state and local level in confronting this problem. This slide shows the epidemic curve by date of onset of illness for suspected SARS cases in the United States. Through April 3rd, there were 100 reports of such cases. 94 of those are in people with travel to affected areas. 4 are in individuals shown in green who have had a direct contact with people who are ill who have traveled to affected areas, and 2 shown in red are healthcare workers who have had contact with other SARS patients. On March 24th, CDC released information that it had recently developed suggesting that a previously unrecognized new coronavirus may be the cause of SARS. To date, laboratories in at least 7 other countries also have evidence of a coronavirus likely playing a role in the cause of this syndrome. Let me provide you with just a bit of background on coronaviruses. These are single-stranded RNA viruses. They are non-segmented, they are enveloped, and their genome is approximately 31,000 nucleotides. There are 2 serogroups that are recognized to cause infection in humans. 229E and OC43 represent the 2 coronaviruses that are recognized to be responsible for about 1/3 of colds. Reinfections with these viruses are common. The viruses contain an envelope. They have an S or a spike protein and an M or a matrix protein, and some of them, in addition, have an HE or hemagglutinin esterase protein as well. These viruses do survive for short periods of time in the environment. There's relatively limited data available, but what we are aware of indicates that 229E virus can survive as long as 6 days in suspension and up to 3 hours after drying on environmental surfaces. OC43 has been evaluated and shown to survive for less than an hour on surfaces after drying. This slide summarizes the laboratory data from CDC through April 3rd, suggesting that this previously unrecognized coronavirus plays an etiologic role in this syndrome. In specimens from 4 patients, we've been able to culture this virus in Vero E6 cells. Electron microscopy performed here at CDC by Dr. Sharif Zaki and his colleagues have found evidence of a coronavirus in cell culture or in one case, bronchoalveolar lavage fluid from 2 patients. In addition, recently developed PCR assays evaluating tissues and swabs have found evidence of coronaviral nucleic acid in 11 patients. Recently developed antibody tests using either an IFA methodology or an EIA methodology have demonstrated evidence of infection in 5 patients. And histopathologic studies have revealed evidence of diffuse alveolar damage, or DAD, which is the pathologic equivalent of acute respiratory distress syndrome, in 4 patients. Let me now show you some images of this coronavirus, first in an infected Vero E6 cell evaluated by thin section EM. You may be able to see the small viral particles along the surface of the damaged cell. In the next graphic, you will see a thin section electron micrograph showing a more detailed view of this coronavirus. And then on a higher power, you can see, using negative staining, a coronavirus particle. These viruses are named for the fact that they have the surface projections resembling a crown around the core of the virus particle, and you can see that the diameter is a bit less than 100 nanometers. Now, this slide shows evidence of virus in the fluid obtained from bronchoalveolar lavage from a single SARS patient, but you can see there the intracellular virus on the right. This slide shows the lung using routine histopathological techniques where you can see evidence of diffuse alveolar damage, and in the center a syncytial multinucleated giant cell. Here is a close-up view of the multinucleated syncytial giant cells seen in the lung of one of these SARS patients. There is much additional laboratory work in progress here at CDC and in many laboratories around the world. Some of our priorities include immunohistochemical staining in an effort to demonstrate virus in affected tissues. Similarly, we're working on in situ hybridization techniques to achieve the same end. And we have virus sequencing underway. Sequencing to date of one of the genes of the coronavirus suggests that it indeed is a member of a fourth antigenic group of coronaviruses, and it has provided, again, suggestive evidence that this is a previously unrecognized coronavirus. That completes my laboratory update. Thank you very much.
Dr. Hughes, before you go, certainly you've given us some very important information. A couple of things, though, if you can summarize the key areas of concern for our viewers, what they should be focusing on at this point in the investigation, and if you can also tell us what CDC and WHO is doing to stop the spread of SARS.
Thank you, Kisa. Let me call the audience's attention to a very timely, very important report issued 2 weeks ago by the Institute of Medicine of the National Academy of Sciences in the United States. This report is called Microbial Threats to Health, Emergence, Detection, and Response. It represents a follow-on report to a report that the Institute of Medicine published 11 years ago called Emerging Infections, Microbial Threats to Health. You will never see a better example of an emerging microbial threat to health with global significance than this experience that is currently unfolding with SARS. You've heard excellent and timely updates from the previous speakers on clinical aspects, epidemiologic aspects, and infection control aspects, as well as some of the laboratory data that has been developed. Let me suggest that this disease, SARS, is emerging for a number of reasons. If you look at this recent Institute of Medicine report, you would see that the expert committee under the leadership of Dr. Josh Lederberg and Dr. Peggy Hamburg identified 13 factors that they felt contributed to disease emergence around the world. At least 7 of these, I think, are clearly germane to what we're currently witnessing with the unfolding of the SARS epidemic. They include changes in human demographics and behavior, issues related to human susceptibility to infection, the impact of economic development and changes in land use patterns, changing ecosystems around the world, the dramatic impact of international travel and commerce, the volume and speed with which we and animals and commodities can move around the world. And we've seen SARS spread very dramatically in a very short period of time. Microbial adaptation and change, which is what makes infectious diseases unique. And then finally, and very importantly, breakdown of public health measures, as a result of which many countries and locales have inadequate capacity to respond on their own to these emerging microbial threats. In looking a bit more closely at the IOM report, you would find 21 recommendations. At least 7 of these, again, I think, apply directly to what needs to be done to confront SARS. We must enhance global response capacity further under the leadership of the World Health Organization and Dr. Heyman's group. We must continue to work to improve global infectious disease surveillance. We must rebuild domestic public health capacity at the local, national, and global level. We must develop diagnostics. Obviously, one of the critical needs right now is rapid, sensitive, specific diagnostic tests for SARS. We must educate and train the multidisciplinary workforce that is required to confront these very complex challenges. We must focus on vaccine development and production. Clearly, there is a need now for efforts which are already underway to proceed rapidly to develop a safe and effective vaccine for this disease. And then we need new antimicrobial and, in this case, antiviral agents to use along with other therapies to confront this infection. Now, there are many things that we need to know, and we're right in the middle of this, and the future course of this outbreak at this point is impossible to predict. We've heard about the aggressive infection control procedures that need to be put in place when there's an index of suspicion of SARS. This currently constitutes our best available tool to limit spread of this agent. We'd like to know the original source of the virus. We need to know more about how it's transmitted in the community. You've heard about large droplets being most likely to be the most important mode of transmission, but we need to keep an open mind in terms of fomites and the possibility of airborne spread. We need better information on the risk of household transmission. We need better information on the risk of transmission on airplanes and ships. We need more information on environmental persistence as it relates to decontamination of environments. We need to know the period of infectiousness of individuals with SARS. We'd like to know the explanation for the age distribution that Dr. Hall provided us. There seem to be, in some cases, hyper-transmitters, people who are infected, ill, but unusually able to transmit this virus in healthcare or home settings. We need to know the explanation for that. As more laboratory work is conducted, we need to sort out the possibility of co-infection. We know that other laboratories have found evidence of paramyxovirus in some patients. We need to identify and deploy and implement optimal diagnostic tests. And we need to know the most effective therapy and the most effective approaches to vaccine development. So much has been accomplished in the past 3 weeks since this outbreak was called to the attention of experts around the world. But we're early in this. Much more work definitely needs to be done. I'd like to refer back to the websites of both the World Health Organization and the Centers for Disease Control and Prevention, because these will continue to provide you with the most current, updated information on the course of this emerging global microbial threat. Now, finally, in closing, I'd like to reflect just briefly on some of the lessons that we've already learned from SARS, and we must bear these in mind. This experience emphasizes the importance of strong national and international collaborations and partnerships, the need for planning and practice for outbreak response, and we're reminded very vividly of the need to continue to expect the unexpected from the microbial world. Now, in finishing, again, I'd like to recognize and congratulate Dr. Heyman and his colleagues at WHO for their leadership in this global investigation. And I would like to acknowledge the efforts of investigators and clinicians and laboratorians around the world who are working day and night to control this problem. And finally, I'd like to sympathize with those individuals who've been impacted directly or indirectly by this disease. Thank you, Keisha.
Dr. Hughes, thank you. Certainly appears that we're on the right road to finding out all about this SARS epidemic. Finally, we want to go back to Geneva, Switzerland, where Dr. Julie Hall is standing by. Dr. Hall.
Thank you again, Keisha. In summary, severe acute respiratory syndrome is a very important disease. It's important both in terms of what we know about it and what we have yet to learn about this disease. What is certainly known is that SARS has the potential to spread rapidly, particularly in hospital settings. What is also known is that with early detection and a high index of suspicion, if patients are detected early and the appropriate hospital control measures used and patients put in isolation, then the transmission of this disease can be dramatically reduced. What also is known about this is that the unprecedented global collaboration that has taken place has reaped immense rewards, both in terms of the awareness of this condition, in terms of the awareness of the need for isolation of suspect and probable cases, and in terms of the modes by which transmission can be reduced. However, much further work is required. Work is required, as Dr. Hughes said, to understand this agent in more detail, to get a better understanding of the modes of transmission of this agent, to develop diagnostic tests, to develop treatments, and to develop a vaccine. All of this is only possible through continued global collaboration, and I'd like to take this opportunity to thank all the partners, all the organisations and institutions within the Global Outbreak Alert and Response Network who have contributed to the effort that has been ongoing with SARS so far. I'd also like to thank CDC for this opportunity to be involved in this broadcast. So, in summary, thank you all very much for this, and I'm glad that we've had an opportunity to raise awareness of SARS and awareness of the need for us to collaborate together to reduce the transmission of this disease. So thank you to CDC and back to CDC.
And we appreciate you, Dr. Hall. One last reminder for our viewers, don't forget to visit the CDC and the World Health Organization websites for the very latest information on SARS. Again, those addresses for you. The World Health Organization website's address is www.who.int. The web address for CDC is www.cdc.gov. And it certainly has been my pleasure being your moderator for this broadcast. I'm Keisa Daniels, and from everyone at the World Health Organization in Geneva, Switzerland, and from all of us here at CDC in Atlanta, Georgia, goodbye.